Yes, sir.
All right, so I'm Dr. Deuk. It is June 20, 2017. We're at the Surgery Center of Viera here in Melbourne, Florida. It's a beautiful day to be at the beach or in the operating room. And if you're watching surgery today off of a link to the website, you are watching a live stream. You're welcome to call in or type in and ask questions during surgery and I'll answer them. On the other hand, if you're not watching today, then you're watching a video archive of the surgery, which we video archive all of our spine surgeries. So either way, enjoy the show. What you're going to watch today is a Deuk laser disc repair, which is a surgery done to endoscopically repair discs that are herniated and symptomatic through either discogenic pain or radiculopathy or radiculitis. This patient did not want to have a fusion. Are you comfortable? All right, we're going to get started. This is Dr. Deuk. Patients are always awake, and you're going to hear me talk through the whole surgery. There's no editing or narration. All right, so we got 3 discs to fix. We're going to go left side 3-4, correct? Yes. And then right side 4-5-5-1. Yes. So we'll start with the right side. We're going to numb first in the skin. Now you're going to feel a little stiff and a burn, okay? I'm just numbing you up. If it's uncomfortable, you say ouch, but don't move. No, I want her awake. But you can give her a little something just to keep her awake but make her more comfortable. So I'm going to be injecting. While I'm doing this, if you feel any pain, just say ouch, and we'll stop and we'll give you more numbing medicine, okay? But don't be moving around, so stay still. Okay? Deal? She say yes? Yes. Excellent. Now what's really neat is we're going to do a discogram. Just lay still, we're numbing you up, you're doing fantastic. 3 cc's injected. So we're going to be doing a discogram in a few minutes once we get our needles in place, and we're going to be able to ascertain just how painful each of these discs are. So we're going in on the patient's right. Just lay still, you're doing really good. Everything is okay. Sleep shot. Alright, so Drew, you want to go to a lateral? So I'm going to be going back and forth between an AP and a lateral view. Are you comfortable? Patient is wide awake. They're laying on our Jackson spinal table, right?
Yeah, flat top.
Flat top. All right, Drew, we got to clean that picture up. It looks like I'm a little bit south of where I want to be. So I'm just going to redirect. We'll do a little bit of numbing medicine as we go along. Shot. Yeah, I mean, if you can, reduce your field of view, we know that's 5-1. Please lock it too because it's moving. Now my job is to basically get this needle into the L5S1 disc space. I really need the picture closer. Can you bring that fluoro closer to me, please? Thank you, Dr. Pointer. Let's see what you got there, Drew. Go ahead. It's way overexposed. length of the facet joint, basically, if I have one. And I'm going to come into the disc base at the bottom of the disc. That's the facet shot. So I'm basically sitting on the facet joint right now, docked on a lateral aspect of the facet joint. Shot. Shot. So we need to be north just a smidgen. Shot. Looking pretty good. Shot. Are you okay? Is she? I can't see anything there. Is she uncomfortable?
A little bit.
You got that attitude button on?
Shot. Is that better, or are you still uncomfortable, dear? Shot. Still uncomfortable? Drew, it's too grainy. I mean, you got to do something different. I'm not sure what it is, but. Shot. Is there any lead blocking it? No. So, by the way, for patients who are awake,
Carrie.
Oh, I'm sorry.
we don't play this.
We don't play it, okay.
No. Right, so something soothing and relaxing is appropriate. Carl, we're talking about that already. I don't want to keep talking about it, okay? That's your responsibility. These are your kingdom over here. All right, Drew, how are we doing? Wow. Shot. That's a little bit better. Shot. I think if you just zoom in a little bit, Drew, I think you're just too far away. Yeah. Now make an adjustment. Give me an AP real quick while I got you there. It looks like the lateral trajectory is good. So what I like to do is I like to bring the needle in on the lateral trajectory and hit the lateral part of the facet joint with the tip of the needle. Once I dock the tip of the needle on the lateral, superolateral facet, then I'll redirect.
Fine.
Looking pretty good, huh? Yeah, we're right there at the pedicle. Kind of the lateral-ish border of the pedicle. It looks really good. Are you okay? You need the patient awake. Where do you feel that? Where does she feel it? So,
Left or right side?
so the key is we don't want
Right side?
to go down to the
Your
leg.
buttocks or your legs? Upper back one.
Not your leg. Go lateral. So I feel like I'm in the disc. So we have no leg symptoms, which is good because we want to be in Cameron's triangle. So we're just between the nerve roots, the safe zone. The AP view is nice. Yeah. The lateral leaves a little bit to be desired. I think that's good. Shot. Boy, Drew, help us out here. All right, that looks fine. Let's go ahead and do the next one. So at this point, since we have our new 5-1, so L5S1 is notorious for endoscopic transforaminal surgeons to not be able to get into. And apparently, according to some of the surgeons, 50% of them abort 5-1. We have never at Duke Spine Institute had to abort L5S1 in 10 years of me doing these procedures. There's the right way to do it, and then there's the other ways. Are you comfortable? Good. So, you know why we keep patients awake, obviously, during this part is we want to make sure we don't hit the nerves. Because if we do, they'll say they have pain going down our leg, and it's extremely rare that we would ever have that kind of problem. Shot. Where, oh where? And we're injecting some numbing medicine as we go in. Shot. You see it? Is that it?
Yeah.
It looks like we're lined up if that's the tip. Shot. Wow. Is that really all we got? Drew? Give it all you've got. Come on, Scotty. Drew is telling me he's doing the best he can. One more? Drew, I thought you were used to handling these kind of situations. Alright, so we're on the facet shot. We're lined up to go into the disc. Everything here is looking good. Are you comfortable? Now, remember, she has really arthritic shot facets. So, because of all the arthritis of the facet joint, this young lady, shot, is going to be challenged to get the needle past the facet. I feel it. We're right there on the lateral part of the facet. Shot. So, we want to wrap around. Are you comfortable? I'm changing the direction of the needle. Shot. Looks perfect. So we want to change it and aim lateral because I'm hitting. Where do you feel that? Shot. Where?
In your back.
In your back. That's good. We don't want it going down your leg. I feel like I'm on the disc. Shot. Perfect. Right on the annulus. And perfect. Absolutely perfect. Doesn't get any better than that. That's us right there? Alright. Drew, I think we're going to glow green by the time we're done in here. Am I right? So, with 5-1, you've got to be lateral, kind of where the skin drops off to the side. Not quite that far lateral, otherwise you can hit something, organs, intestines. So you want to be just before the skin starts dropping off. You really want to be as medial as you can be without being too medial. Does that make sense?
Yeah, it's my lines.
It's your lines, your lines. So now we're going to go to the other side. And because this lady has leg pain on both sides, right and left, she has pinched nerves on both sides, right and left, and really 3-4 it's on the left side, and 4-5-5-1 it's on the right side. She's got rotatory scoliosis. So if we did an open surgery on her, she's going to be in the hospital, you know, unless I do it, of course. She would be in the hospital normally with other surgeons for probably a week or so, recovering. Or getting an infection or some other complication, like a blood clot, very common. But this is outpatient, and she won't need a big surgery if this works. Shot. And this works 90% of the time, way too high. Did you do this one? You did this? No, I'm just kidding. I'm messing with you. So, shot. That's nice.
Yeah.
The only problem is I'm not on the facet. So it must be too far lateral. There's a facet. I feel it now. Perfect. So since the facet is sensitive, we're going to just do a tiny little half a cc, quarter cc of numbing medicine to keep the facet happy. It's a little medial branch or facet joint injection there. Really more for the procedure, just to keep the patient comfortable. So you can see we're lined up beautifully for the disc. I just got to wrap around the bottom of the facet. So I can angle my needle so that it aims around anterior shot. There it is. Then I'm going to turn it and aim medial. Where do you feel it? What'd she say?
Right where.
In your back? Is that it there?
Yes. Yes.
Is that it there, Drew?
Yes.
Shot. Just relax. We're almost done, Shot. Give me an AP. So this is where there's a large herniation at 034 on her left side. And that's what we're starting to come in contact with, is that herniation. And it's so sensitive for her. Yeah, that's where we are. It's beautiful. You're going to do so good after this surgery. I'm really excited for you. So, go ahead and go back to the lateral. Oh, give me one AP while you're there. Give me an AP while you're there. Yeah, now go to a lateral. And you see she has scoliosis too, degenerative scoliosis. We're not fixing the scoliosis. We're actually we're going to hopefully fix her back pain and her leg symptoms, because the scoliosis itself really doesn't cause anything. So, a lot of people think it does. All right, so the moment of truth. Are you comfortable? So at this point we're going to do a discogram. She doesn't know what we're about to do, but we're going to be able to see whether this is a painful disc for her. You comfortable?
Yes.
Stop. Beautiful. Not responding? Alright. So that's a 4-5. She doesn't have any axial pain there from her disc. Now let's check the next one. You guys have more Darko?
Yeah.
Yes.
How much of her pain is back versus leg? Anybody?
He said most of it's in her back.
More in the back.
Yep.
Okay.
And occasionally it goes down her legs.
Oh, there it is. How bad is that on a scale of 1 to 10?
10.
10. Okay, is that your typical pain? See? That's a beautiful example of, you saw it, right? One disc injection didn't bother her back, and the other one, so her back pain is coming from that L5S1, and I have a feeling L34. Because remember how tender that disc was? I bet you that one's going to be uncomfortable. Is it better now? Are you comfortable? Yes, somewhat, she said. So, but you're not having that pain anymore, right? Good, good. How bad was that? A 10. So L34 and L5S1 are positive on the discogram. Who's documenting that? Can you write on my op note?
Yep.
Just put discogram concordant, CONCORDANT, 10 over 10 at L3-4 and L5-S1. You can see all the diagonal in the epidural space around the side. You see it leaked out through a big tear. All right. Okay, it's time to go nighty-night. So can you count to 100 by ones out loud, starting at 1? Okay, here's our blood loss for the whole surgery. Right here. Drew, let's see what I want you to do. I want you to stay where you are for now. I think we should do 5-1 first, right? That'll be the, so they don't get in the way of each other. Keep counting nice and loud. Shot. Do I really need to see 5-1? Is there any way you can focus at that level there? I don't care if we don't see 3-4, 4-5. Shot. Whatever you can do, maybe push it in a little more or something. Let me know when you can take a shot. All right, I see the guide wire. You see it? So we'll take this needle out. Now we have this guide wire that's going all the way transforaminal into the L5S1 disc. And we're going to bring our dilator right over it. And the dilator basically not going to cut anything. It's just going to chop. It's just going to separate the muscle and spread it. And then we're going to bring our tubular retractor in. Shot. Let's see, you can see the tip of the guide wire. I want to always watch that to make sure it doesn't advance into the pelvis. Now I feel like I'm going past the facet. Shot. Now you notice this patient is asleep, okay? And they actually have to be asleep at this point, because if they're not asleep, hey, lay still. Yeah, so she's starting to wake up a little bit. This is very tender, painful. Remember, this is one of the painful discs. So she's squirming around. We need to get her a little bit more in control. If you want to use a tiny bit of fentanyl, that's fine. You want me to wait? I'll just sit here and wait, no problem. So we know this disc is extremely painful for her. We did a discogram, she had 10 out of 10 pain. She nearly came off the table, and now what we're doing is we're entering that disc with this dilator and then tubular retractor. We're going to go inside the disc and repair it from the inside out. But to do that, we have to go right past the painful part of the disc, because that's where we want to be. We want to get rid of the painful part, so we're going through it right now in order to repair it. And that's why it hurts her so bad. Is that her blood pressure?
No, it's been going, so it's not. This is
Just lay still.
144.
Okay. Lay still, remember our deal. So she's good? So to be able to do these kind of surgeries, your patient has to be cooperative, and you have to have a good anesthesiologist. Because once you start going through that painful part of the disc, the patients are going to want to move. And, unfortunately, they're kind of half awake, and so they're not. And just lay still. They're not, the most cooperative. Shot. All right, that looks like we're getting in there, right?
Yep.
It's good. Shot. Can't really see, Drew.
Yeah, I see.
I can't tell for sure. Is that it?
Half of the.
Yeah. So we can take the guide wire out, right? You sure, right?
Oh, yeah, of course.
Yeah, it looks good. A problem here, for those of you watching, is really this is unfortunately a very large woman who has a lot of soft tissue. Shot. And so that x-rays have a hard time. I need something. Shot. That feels pretty good right there. It looks good. So we've got this dilator now through into the disc where we want it. We're going to put a tubular retractor. We're going to do the entire surgery arthroscopically through a tubular retractor.
Turn the laser on.
Laser on is good. Should be ready for it soon. Okay, still squirming around a little bit. Shot. Shot. Shot.
Yeah, I'm at the highest level you give me.
Yeah, we're kind of the limits to what we can do here. She is shot. I think that's good. That looks good. All right, at this point, you can just keep the flow where it is. It's fine. We're at the limits to what our machine can do, and we have the best fluoro machine you can possibly buy, so. Huh?
That's for sure.
Right?
I've seen that, man.
Hey, yeah. All right. Let's do this.
See, that's what I was telling you. It was the bottom.
Yeah. Hey, if you're happy, I'm happy. As long as it's under good control, I'm happy. Scope on. All right, so at this point, we're going to turn on our irrigation. Shut down our suction a little. You see that blue disc? That means we're in the disc. So that's a good sign. Let's get some of that. There's some of the herniation. Grab it. Yeah, take a picture. Get some of that out. But this is, we know, a very painful disc. And we're going to help this lady by removing the herniation. And then really cleaning up the annular tear. Take it. I don't like this here. Is there any way we can bring the flow out?
Similar.
Yeah, watch out for that.
Similar.
If you can just maybe pull it out a little bit. That's actually good right there. Are you okay? Actually, a little bit more. Are you okay, Gusto, if it's there?
You need to be comfortable.
I'm fine. Are you okay? Well, I don't want you to contaminate that either. You can bring it back to where it was. North, so good. That's perfect. Okay, laser, and I need my pedal. Laser's on 30. This is a Homey and Yag laser. 30 watts, 15 joules and 2 hertz. And that's the standard frequency and power unit. And that's a fresh tear. Look at that. I mean, that's a fresh annular tear. Little fluffy clouds of annulus. This happened recently. And when I mean recently, I mean this didn't happen 20 years ago, 30 years ago. It probably happened in the last year or two. So that's probably why she's having a lot of her back pain at this disc. It's kind of an acute injury, subacute. I wouldn't say acute. Subacute injury. Acute means, you know, less than 2 weeks. Clearly she's had these issues ongoing for a lot longer. So this is definitely a soft disc herniation as opposed to a very calcified disc, at least so far from what I can see. That may change as we get into it more. We may find some parts of this herniation that are older. But right now, this looks like a young disc herniation. Laser off.
Okay, stand by.
Grab her. So we're grabbing laterally there. So medial is at 12 o'clock. Okay, that's the top of the screen. Who is it? That's my phone. That's a herniation right there.
You want me to answer?
Who is it?
It is Steve Healy.
Yeah, just tell him I'm in the middle of surgery. Tell Steve Healy I say hi. Take.
Okay, I'll let him know. Okay, bye. So call him anytime.
Thanks. Oop. Hey buddy, laser. You gotta keep an eye on it. Yeah, we're ready. As soon as you see me grab the laser and start going in, that's your cue to turn it on. So there's the annular tear, by the way, right here, zapping and debriding the edge of the annulus. That's really what we spend. Probably 80% of our time is on the annular tear, maybe more. You know, that'd be a good study, Augusto. What percent of the surgery is on the annular tear versus the discectomy? Right? Yeah, you can see it. Wow, look at that tear right there. Look at that thing. How ugly it is. That's not normal. There should be a white band of annulus right across there. That's why this lady has so much pain in her back, is from that tear right here. And we're getting rid of it. So I think she's going to be very pleased with the results. So we had a little bit of challenge with the fluoro in the beginning, but I think we're making our way through this surgery. So Carl, is our scope being fixed?
Yep.
These scopes that we use are manufactured in Germany. They're all FDA approved. They're made by a company called Wolf. And every time they have a little problem, we send them in to Germany. Are they working on them in the United States now, or do they have to go out to Germany?
As far as I know, it's done here.
Yeah? Where, so they have a shop here?
Yeah.
Where? You know? It usually runs about $2,000 to $3,000 to fix them every time they break. And they do break quite often. That's the one downside. You can't torque on the actual scope. If you want to pull on anything, you pull on the tubular retractor at the top. That's what I'm doing right now. Trying to get over medially. See that big blue thing right there, wedged in between the white? That is the interposed nucleus pulposus that I talk about in our papers. So that is what causes the back pain. It's nucleus pulposus degenerating. As it degenerates, it breaks down, and it creates inflammation in that white part that it's wedged in between. Right there, there's some scar tissue right there. I'm zapping it away. That's where the little nerves are that cause back pain. 99% of neurosurgeons and spine surgeons have no clue of what we're doing right now, and that this is what causes the patient's back pain. They have no clue. No clue in 2017. Absolutely no idea. They've never seen this surgery. They've never seen this, what we're doing. They've never done arthroscopic spine surgery. So we're going to come back a little further, and there's some more annular tear right there. See it? And again, we need to zap it away. The reason why we're doing a debridement of this annulus is that the annulus is trying to heal. It's trying to get back together with its buddy on the other side. But what's blocking it? True? What's blocking it is the interposed nucleus herniation. That's the jelly from the center that's squeezed out between the tear. So that jelly is avascular, and it cannot become vascularized. Nucleus pulposus, that's right. That nucleus pulposus is blocking the annulus from healing. And it's creating constant inflammation because the annulus is trying and trying and trying. Like a little 12-year-old playing a video game over and over and over again, trying to pass the level boss, we call them.
Oh, like a Drew now, when they play the game.
Yeah. So a level boss in a video game is the really, really difficult monster or challenge that you get at the end of the level. And when you play a video game, usually you try the first time and you fail, you try a second time and fail, and you keep trying over and over and over again, constantly, trying to beat the level boss, and you keep dying and being reborn. Right?
Yep.
So that's what this annulus is doing. It keeps trying to heal every day. Heal, heal. And it can't get across the chasm of nucleus that's wedged in there, blocking it, keeping it from succeeding, thwarting its efforts. It's like a level boss. Thwarts your efforts to finish the level. And it's truly an adversarial relationship, because the annulus, it doesn't want the nucleus there, just like the gamer doesn't want the level boss there. That's why he has to defeat it, vanquish it. So the annulus has to vanquish the nucleus, but it can't do that. But it keeps blasting it with inflammatory mediators. And every time it does, it releases more nucleus, which creates more inflammation, more scarring. And it's a vicious cycle over and over again. It's beautiful, but nobody understands it in 2017 but us. Maybe Dr. Anthony Young, very, very few surgeons. Maybe 5 out of 20,000 spine surgeons understand that in this day and age. But if you're watching this video 10 years from now, it's going to be common knowledge. That's what's amazing. It's not common knowledge yet. So is that just a little air bubble or a piece of schmutz in the middle? You see it? It's bugging me.
That's on the lens.
I hope to God that's not another busted lens. Is it?
It might be in between there. I mean, we can pull that off and wipe the.
I know, I'm going to get to it. I'm just on a roll here.
Hopefully it's not.
I'm making some progress against the level boss. But look at all that scar tissue. Now this is an older injury. Remember earlier we saw soft, easy, fluffy stuff? This is hard. This is really scarred. Look at, there's the tear. Still some more of the tear right there. So we're following the tear from the inside of the disc to the out. And we're debriding the annular tear. You can see this whole time that we've been in here, we've been debriding the annular tear, but also removing some of the disc. Now why is it pretty blue color? Because this patient is a Deuk spine fan, and they have a blue disc for us, because that's our color. No, we injected indigo carmine, which is blue. Right, Carl? A 10% solution?
Yep.
And that indigo carmine actually stains the herniated disc material. You can see it all wedged up in there, in that annulus. At this point, we're getting close to being done. The tear is extended to the periphery of the disc. We are pretty much almost at the complete periphery. Remember, this is the first of 3 that we have to do. Augusto, what's happening? You sure?
Yeah.
You feeling better?
Yeah.
How's our first patient doing? Are they ready to go home? That'd be great. Just call on the phone. We do have telecommunications. It is new here. I'm glad she's got a sense of humor. This is a lateral part of the herniation. This is like foraminal, extraforaminal. It's pretty much done. Going back medially, we're just about done with this disc. There's some fat in the epidural space. You see it? Little vein there. We saw that earlier today with the other surgery we did, right, Augusto? You don't get quite a zoomed in view. A little secret about fat: when you compress fat, which means you squeeze it, for a long time, it actually disappears. So when you have tight stenosis of the spine for a long time, there won't be any fat. And that is something that we typically see in patients with long-standing spinal stenosis. So if you look at right where the laser is, that's at 12 o'clock. Just behind that metal is going to be the traversing root. The root that goes down to the next level. Since we're at 5-1, that would be at the S1 nerve root, right? And the exiting root, which is the root that's leaving at this foramen that we're in, is going to be right here at 9 o'clock. You want to see it? Augusto, you want to see it? Of course you do. So the first 2-level lumbar fusion is about ready to go home? Is that what you're saying? That's great news. And she's already peed. Praise God. And that, has she gotten her second dose of Tylenol?
No,
What?
6 hours since.
6 hours? Hasn't even been 6 hours since she's been here. We're flying today.
That's what I said. It needed to be 6 hours after the first dose.
No, she got the second dose.
She did.
She got the second dose
Yeah.
already?
You got an IV, right?
Yeah, I used the second dose.
Oh, yeah.
Remember, we didn't do the oral because,
She's going to start responding right now. I feel her moving and
They
wiggling.
don't do the
well,
oral.
initially, I told Karen, we weren't gonna do the oral again.
Oh, they don't do the oral?
Now, no, sorry.
The next
we did
case.
the oral and we were
Yeah.
gonna do the IV, but now we're gonna do the IV first.
Yes, I know.
All right.
Today, we didn't do the IV first, we did oral.
Yeah, but the IV is 6 hours after.
Yeah, IV's in,
Oh, they
So went
do
in.
it?
She got
They do
both.
it?
yeah.
Okay.
All right, good. Alrighty then. Just about done here, cleaning up a little bit. She's not happy with me right now. She wants to wake
Close
up.
to the nerve.
Yeah, we're just about done. So I think we're done. I'm gonna take laser out. Get that medicine ready. I'm gonna show you the nerve. Okay, it's actually right here. Oh, there's too much fat around it. You can't see it. All right, well, that's where it is normally, and that's where this one is. You can see where the herniation is relative to it.
The spider is broken. It is,
The fiber's broken. Scope after. Take. This is coming out. I'm going to reach over. I'm going to take this tubular retractor out and apply some pressure to her muscle. I'm keeping the other needle from coming out. Take, please. Great. So we've done one disc. That's L5S1. We're getting ready to do the next one. I'm going to apply a little pressure to her paraspinous muscles because that's what usually will bleed, if anything.
the other little thing.
Sure you're banging my kneecaps? You're banging them? You're banging them? All right, let's get the scope in. Let's bring the scope in. You don't like me, huh? Trying to take my kneecaps out? Or you aiming for something else? You know it's down by the kneecaps. All right. Let's get a guide wire. Okay, I'm going to hand this to you. Nice even exchange. So the next disc we're going to do is L45, again to the left side. Let me know when you're ready, Drew. And let's go ahead and get a fluoro shot. And this one? I don't think that's the case. That doesn't make sense. If the laser fiber broke in it, you wouldn't see it.
It goes out the side when it's broken.
No. Is it really?
Yeah.
I didn't know that. Shot? So you're saying we have a broken scope now?
It doesn't say that might be the case.
Another broken scope, another $2,000 to fix it? Oh, freaking A. It's okay. It is what it is. Okay. Let's get this lady feeling good. So now we're going to go into 4-5 shot.
Here, I've got.
That's where we are.
What? You have a cleaver? I don't have that. We can score it with a knife.
She's feeling it. She's a little bit uncomfortable shot. All right. Shot. So the guide wire takes me right to where I need to be. And that is wonderful because it protects all the other structures around. Can you turn this light on? On. Now let's. Thank you. Shot. Is that it? No, yeah. Beautiful. Shot. All right, so we can see that the tip of the dilator is into the space. So I'm going to take that off. I'm going to hold it steady. I'm going to take the guide wire out. I like my trajectory. It's 45 degrees. I'm through the disc. Tear, shot. Perfect. Let's get the dilator, the tubular retractor. And we're at the L45 level now. There's a little mark right here on this tube. Right here, you see that? It's like a black rectangle. That goes to the midline always. It's important. That's where the opening of the tubular retractor is. It's aiming towards that black mark. Shot. Ooh, you're really testing my patience today. Shot.
I'm trying to find the best image.
I know, I'm kidding. I know you're doing your best. I think you're going to find it by the time we're done. Shot? I think it looks good. What am I smelling?
That's horrible.
That's not Mexican. No, it's not that. It smells like a ether-based medicine. Volatile.
Can I leave it with this and get a better? Yeah.
Some kind of chemical. Nothing? Alright. Let's head down here. Down into the tubular retractor with a scope. Scope on. Oh, here we go. A little more, Drew. Yep. That's kind of like a sling for me there. All right, that's good. Grab her. Everybody happy? Can you guys hear me okay?
Yeah, we can hear you.
Sometimes I feel like I'm talking to myself down here.
Yeah, we can hear you.
Disc material, disc herniation.
Get it? Yeah.
Any questions from our audience?
No, sir.
This disc is just shattered. Again, how old is our patient? I'm sorry?
68.
68. Okay, she's 68 years old. This is real interesting. She's almost 70, right? And if you look at this disc to me looks like a young 20-year-old disc. So clearly, she was doing all right for a while. And I think recently she had some problems. But for the most part, you can be older and have a beautiful soft disc. So here we go. Laser on.
Ready.
Nice job of repairing the laser, gentlemen. Carl. Thank you. And that schmutz is off of the scope, by the way. So it was just something on the lens. A little bit of disc material probably. This stuff is sticky, you know? The nucleus, like when it's like this, when it's not totally degenerated, it's very sticky. Almost like snot. We got a piercing. Stand by. Wipe that off. Yeah. Thank you. On. What are we listening to? Bing Crosby?
I just found some easy listening, so yes, we probably are. But I can change it back now.
Well, she asleep? She's asleep? Nothing too hard. Maybe something, you know, who knows?
Well, let's
No, nothing hard. No hard rock and roll.
no urination.
Nah.
How about some 80s pop?
Yeah, sure. Why not? Laser standby. Grab her. This music is about to put me to sleep. I've never fallen asleep. Well, actually, I did one time in the OR. I was doing my internship at Shands Hospital, cardiovascular surgery. I was so exhausted. I fell asleep while holding the heart. Of all things to fall asleep doing. But crazy thing is I slept standing up. Standing up. Sleeping. It's amazing.
It happened to me on the bus.
On the what?
When I've been in med school on the bus, back to my home.
Yeah.
Did you wake up and they were in the bus?
One day,
Look at that herniation there coming out. Beautiful. Stand by.
on the train.
Grab her.
You know the station and everything.
Here. You fell asleep in the bus?
And the bus, but one time on the train.
Yeah, but that's not a big deal.
No, the problem is I'm waking up and they don't recognize anything from the window. I say, where I am?
Yeah.
Bus 3 or 4 steps. I need to go out, come back.
Oh, I'm heading to England this September.
Yeah.
Yeah.
Wish I could go.
Why can't you go? Time. I'm your boss. I give you time off.
Good. I like it. And in September it'll be good. Where are you going?
We're going to a race.
Oh, you go to Silverstone.
I'm not sure what the city is. But it's a world championship.
I loved it. Chicago Square,
No, we're not going to London.
British Museum. You take a train in?
No idea how we're going to get to this place. I have
How far away from London is it?
4 hours.
How about the pressure on the stuff?
I don't think we're going to get to London, to be honest with you.
There are trains over there really fast.
It doesn't matter. We're going to be at the racetrack every single day.
Yeah.
It's during school for my kids, so
Reach it back.
thank you. So I have to be very careful with how much time we take off. So all those bubbles were because we just switched our irrigation bag. What do we use? 5 liter bags?
3,000.
3 liters? So again, look at this fluffy, soft disc, right? This does not look like the kind of disc you would normally think of for a 7-year-old woman. And I don't mean to give her two more years, but 68, you know? I know, 2 years. She'll kill me. Please don't get angry with me. I know you're going to watch this later, but I'm not trying to. Yeah, I give all my patients. Oh, yeah. Patients love watching their surgeries. It's, you know, part of their record, and if they want it, they can have it. I think it's kind of neat. You know? We don't give it to everybody, we give it to them if they want it. They have to request it. She wants a copy. Standby laser? But, you know, the key point though is that everybody thinks when you get old your discs get bad. They don't, you know. They can be very soft like this one. If I were to show you this disc and you have no idea how old the patient is, you would think, if you've seen as many thousands of discs as I have, you would think this is a 25-year-old patient. Because the disc is so soft and fluffy. Well, yeah. Honestly, I don't believe. I don't think so. We see people that are real skinny with disc problems and people who are overweight, and I just don't think that the weight has anything to do with it. That's what you hear people talking about, but I don't think it's true. There's a lot of misinformation out there about back and neck conditions. Maybe knees, it's true, or hips, but
It looks good.
Wow.
That's long.
what is it? How come you guys aren't letting me in on it?
I should get a laser.
You strip the insulation.
Oh yeah, I see it. I don't even look at that part of the laser, you know? I'm so busy looking at the tip. Oh, it's working. Did I ever tell you about the time I got zapped by the laser? Like during a lumbar laser, just like this. One of the, like in my first year or two doing this stuff, I was like really twisting here like this.
Yeah.
And I'm like really into it, trying to get that piece of herniation out, and suddenly I just felt the most intense pain. Imagine a wasp, imagine 5 wasps stinging your fingertip all at the same time. I mean, it was crazy.
The same energy?
Huh?
Same energy?
Oh yeah, this. It went right through my finger. It almost poked out the other end. I took about 4 bursts before I realized what was happening and got my foot off the pedal.
Oh my God.
Yeah, I looked at the hole. I still have a scar today. I looked at the hole, and it went all the way to my bone and my fingertip. You know what I did? Changed my glove and finished the surgery. That's how much I love the surgery. It's just such an amazing surgery. You just get into it.
Did you have to put a stitch in it?
Nah, it was cauterized, it was clean, it was just a hole.
Very precise.
Yeah. But people, I laugh at these doctors who say, laser can't do anything, you know, it's all nonsense. I mean, you can see the laser is hitting the side of this tubular retractor, and you can see that it's literally welding, melting the metal down there. This tubular retractor is not so bad, right, Carl? But there are ones that they have all these welded spots, these blast marks. Yeah, this laser can easily go through metal. And people say, oh, well, how are you going to go through a bone spur? It goes through stainless steel. Trust me, it can go through a bone spur.
Hey, can you check the suction? Is it full?
Yeah, we got one full one.
I think the full one is the suction over here.
What's that?
There's the tear. You can see it really good right there.
It helps that your cannula is non-reflective.
Yeah. Yeah, they designed the system really well, those Germans. You know what they're doing? They just don't know how to market this stuff. You know, it costs a lot of money to educate people how to use it, and it's extremely difficult to learn. The learning curve is so steep that, you know, you pretty much have to be a surgeon, a spine surgeon, to learn it. And you have to be a spine surgeon because if you have a complication, You better know how to deal with it. You know?
But the benefits of the surgery is a lot.
The benefits are incredible. Look at the incision. 1 7mm incision. I repaired 2 discs. We just did a lumbar fusion on the patient before this. If I did this surgery instead, they wouldn't have needed their fusion. So this patient here will probably go home around the same time as the lumbar fusion. And this patient would have had a lumbar fusion if they didn't have a laser surgery. Problem is getting insurances to cover it.
What's the recovery time in comparison of these two?
No, it's totally different. This patient's going to be walking around tomorrow back to a normal life. I mean, they'll have a little bit of muscle soreness where we did the surgery, but they're going to be back to walking, driving, shopping for groceries. They go back to a normal life tomorrow. Whereas the fusion is going to be sore for weeks. Not able to drive a car, out of work for 2 weeks. This patient can go to work tomorrow if they wanted to.
It's amazing.
Yeah, it's totally amazing. You can see this tear. Where else do you work with your laser?
I go to Home Regional.
You work with urology?
Urology, ENT, GYN.
What do the OB-GYNs do with these lasers?
Well, we use different. We use different.
Ah,
Yeah, papilloma.
my favorite.
CO2 energy, so papilloma.
CO2?
Yes.
Not holmium?
Not all.
You can get it in your nose.
I didn't know that.
You're doing this, they come with papillomas.
Are you serious?
Yeah, you can get up in your nose and get cancer in your nose. Papillomas.
You mean the doctors who treat it?
You can get them in your throat. They have to have, there's a special suction that you gotta use too.
I had no idea. That's horrible.
It's true.
Oh my God. So they vaporize the virus and then it goes into smoke?
When I was doing
incredible.
when I was doing my clinicals, it was
This
a
is all
kid there
scar
that
tissue here, by the way.
had,
All
that
this
had
white
HPV
stuff.
in her throat.
Yeah, but that's because they're born
Yeah.
through the birth canal with HPV. But getting it through smoke, that's weird.
And all her mom had to do is have a C-section.
She had a C-section?
No, that would have prevented it.
Yeah, they would
And
have
she knew
prevented
about
it.
it. She did.
Well, the same thing happens with Neisseria and herpes and all the other STDs that
So messed up.
some of these people have, unfortunately. Pass it on to their kids.
Yeah, but if you can prevent it.
This is all scarred right here. This is dense scar tissue. See the difference here? It's not fluffy white stuff. It's really thick scar tissue. This injury is older. This is a part of the disc that has been under inflammation for a long time. See the difference? Fordham?
I walked into a room before when they were doing that, and nobody was wearing anything, and I was like, what are you guys doing? What's wrong with you?
Yeah, Gusto. Are you serious? At Parish? Augusto, we need to submit that. We need to write that paper for Young.
Okay.
Okay? You've got to remind me.
Okay.
Remember he invited us? Did you see the email?
No.
I'll forward it to you.
Okay.
He invited us to submit a paper for publication
Oh, okay.
on this endoscopic laser surgery. Cervical.
Okay.
All right, just about done here. One more minute. You can see the tear right there, the last bit of it. Gonna vaporize it. And we're just underneath the nerve root there. This is the last of the tear. We're just about finished. And we got one more to go on Augusto's side.
This similar to this spine.
No, they don't know how to do this. They do a standard laminotomy microdiscectomy with a tubular retractor. Most of the time they don't even use a laser. They just use it.
With the microscope, like whether you use the microscope they opened up for. This is the smallest incision I've seen.
Yeah, there are very few people in the country, in the world that know how to do it like this. Mostly in Asia, Germany. Only a handful of us in the United States, but laser spine doesn't know how to do it this way. This is more advanced than what they do, and much better for the patient. A lot more effective. That's it, laser off. Shut off my irrigation. Hopefully I can show you guys the nerve on this one. Let's see, there it is. Just there, that white thing. There's the discectomy. Yep, created a lot of space for the nerve. Scope off. Transforaminal. Right? We're in the foramen. Right around the root. Yeah. I mean, we're rubbing on the root, so, you know, we're pushing it over and irritating it. So this is nice.
You gotta come in this side.
Yeah.
She can take it and throw off. You know,
I gotta get in the next disc.
You can go in over here and then go to that side when you go inside, right?
Yeah, yeah, you're right. Alright, Drew, we need a lateral. So we've done L45, L5S1, laser disc repair, Deuk laser disc repair, as we discovered this technique. Modified what Dr. Young had done and other endoscopic surgeons and improved on it. So we're going to go to L34 next. Let me know when you're ready. All right, looks good. Shot. Perfect. You can see the needle tip is in the foramen. Incision. We already numbed the skin up earlier. Remember, this is a dilator. Shot. So right there where the top of the disc is perfect. See how the guide wire makes it so safe and accurate. Shot. All right. Take that. Take the guide wire out. Shot. Yeah, that's gonna be nice. This is the other very painful disc that this poor lady has. And you can see it's pretty collapsed. This is probably the worst of all three based on the preoperative imaging. It's very sclerotic. You can see the tubular retractor right there at the back of the annulus. That's good. Is our next patient here?
Yes.
Thank you. Give Drew a second. Get that fluoro out. Touch the tube, Drew. Nice job, guys. Thank you for those X-ray images. Let's keep it sterile until I. All right, so I need the laser pedal on my side, and I'm gonna need, who's in there? Travis?
Yes, sir.
I need you to put the endoscopic view on the monitor.
Okay.
Not the one that the floor is on, the one the eye in the sky is on.
Yep. So you want to go which one?
Actually, it's the one that the scope is on. It is there. I guess it is there. Never mind, it is there.
Yep, I got it.
Well, the floor is up there. The one on the wall. Yeah, just go back. You just change it to eye in the sky, put it back to endoscope. God, I love this system. Absolutely amazing. Light on. Woo, what's going on there?
I know.
It's fine there. It's fine here.
Yeah. There it is. Perfect. All right, thank you. So we're in the L3-4 disc, or in a left transforaminal approach, and that's the herniation right there. This is a more degenerating appearing disc. Laser. We'll just consider it, just keep it there, but I don't think it's sterile. We won't bring it in. Okay, you can see the annular torn fibers. That didn't hit you, right? All right. Thank you. Yeah, this is L3-4. We've already done 4-5, 5-1. Hey, I need to do Augusto. There's a request for me to do a summary. We need to remind me. Stand by. Grabber. Somebody take the laser. There's a piece of herniation. Laser. We've got 10 minutes left. Dr. Fordham.
Okay.
There was the tear. See that? Not much disc. I think most of it was in that foramen, lateral recess. Just a big tear, which we'll clean up.
This is a 3250.
Just days away from the Artist Confidential with Sticks. I'm so happy about this. J-Town handled the guys a couple weeks ago on the Sirius XM Fishbowl in the studios over there.
Well, less of that nice fluffy white annulus, right? More of the older. This looks like this disc was injured a lot longer ago. Several years. At least 5 years, maybe 10. See the tear? There's the end plate right there on the right. There's the fibers of the posterior ligament right there. There's really not much disc here to clean out. But we saw how painful it was. Are we good on irrigation? I'm seeing a lot of bubbles.
I can go. I think there's about 1,000 left.
Right. No, we don't need another bag. We're almost done.
Okay.
So you guys pumped it?
Yeah, it's up for the rest, just barely.
Okay, thanks. There's the epidural space. See the vein right there at 12 o'clock? Try to stay out of it. Man, there's just not much herniation here that we can get out. I think we got most of it. There's lateral. Let's see what we got out there. Really not much. You know? Must be just more of a discogenic type vein rather than a foraminal stenosis. I think that looks good, huh? Try to clean a little bit more. But you know, you go all the way back to the posterior longitudinal ligament fibers through the annulus. That's a bone spur. There's no more disc here. All the way on the other side now. Okay. Let's laser off. Thank you, everybody. Good work. Augusto, you have 2 incisions. Stand by, off scope. What's wrong? What's wrong? Yeah.
is it? I'm out of here.
Yeah, no. He did 1,000 at 8:30? I mean, he should be fine for another 1,000, but I mean, it's 3 o'clock now. 8, 9, 10, 11, 12, 1, 2. I think it's probably okay. We don't have to do it. All right, 2 incisions. Good work, everybody. Hope you enjoyed that. It went very well. I think bilateral, 1 level. Pardon me? Oh, blood loss, 3 cc's. 3. Thank you.